Welcome to this revision video on autoimmune hemolytic anemia. My name's Harry and I'm a Haematology Registrar, and this is intended as a revision resource for other registrars studying for the FRCPATH exams. It's based on the BSH guidelines and it will cover the basics of hemolytic anemia, the different types, additional investigations you need to do, what to do in an emergency and how to treat it normally. So hemolysis is the premature destruction of red blood cells within the body before they finish their normal lifespan. The red blood cells are usually removed by macrophages in a process called extravascular hemolysis, typically in the spleen, liver and the bone marrow. The macrophages phagocytose the red blood cells prematurely because they have an abnormal antibody attached to them. They might be more rigid, or the macrophages are doing something they're not supposed to do because they're either excessively activated by inflammatory cytokines such as interferon gamma, or they're abnormal, like in histiocytic sarcoma, which is a tumour of the macrophages, and the macrophages phagocytose excessive numbers of normal red blood cells. In some patients with hemolytic anemia, dependent on the cause and the patient, there can be concurrent intravascular hemolysis. This is when the red blood cells lyse or pop in the circulation, releasing hemoglobin into the plasma. This then spills into the urine, resulting in hemoglobinuria. So you can identify intravascular hemolysis by hemoglobinuria on microscopy. Autoimmune hemolytic anemia is a decompensated acquired hemolysis caused by the host's immune system, which acts against its own red cells. You can divide that serologically into warm type, which is about 65%, cold type, which is about 30%, and cold hemagglutinin disease, CHAD. 1% of the population might have paroxysmal cold hemoglobinuria or mixed autoimmune hemolytic anemia. In terms of differentials, there might be hereditary causes like membrane issues in sickle cell disease, which cause the red cells to lyse more easily, especially when it goes through capillaries, or hereditary spherocytosis, where the spleen gets rid of the red blood cells more easily. Certain hemoglobinopathies will make the hemoglobin unstable and therefore the red cells will break down. Acquired causes might be autoimmune, so the host's immune system makes autoantibodies against the red cells, or alloimmune because of an antibody from a donor or a mother in an infant. The donor might be from a transfusion or stem cell transplant. There might be non-immune causes from infection like malaria, or intravascular hemolysis from a heart valve. DIC from infections or burns can also cause hemolysis. So in warm autoimmune hemolytic anemia, you normally have the patient's own antibody, which is an IgG antibody. It can sometimes be both an IgG or an antibody against C3d, or just C3d alone. It targets the red cell membranes, optimally at a temperature around 37 degrees. The causes could just be primary, so there is no underlying disorder, or the autoreactive antibody is from a cancer like CLL, lymphoma, or another solid organ. It could be from infections, so hepatitis C, HIV, CMV, Varicella zoster can cause the body to produce antibodies against itself. Pneumococcal infections, leishmaniasis, tuberculosis can also do this. Connective tissue disorders like SLE, Sjögren's syndrome or scleroderma can also cause autoreactive antibodies. Ulcerative colitis, primary biliary cirrhosis or sarcoid can also do the same thing. Causes of cold autoimmune hemolytic anemia is normally an antibody against C3d that binds optimally at colder temperatures, but it's clinically significant if it causes hemolysis and binds at higher body warm temperatures. They're normally IgM antibodies, and they can be primary without any underlying cause, but it's usually associated as a clonal disorder, which means there is a clone in the B cells like CLL or non-Hodgkin's lymphoma producing this IgM antibody. Infections like mycoplasma, viral infections, infectious mononucleosis, or after an allo stem cell transplant can also cause the same thing. Paroxysmal cold hemoglobinuria is caused by an IgG antibody that can also bind at colder temperatures, and as it warms up can cause hemolysis by activating the membrane attack complex. Patients present with symptoms of anemia, so weakness, dizziness, shortness of breath, or hemolysis like jaundice of the skin and dark urine, signs of an underlying disorder like lymphadenopathy or hepatosplenomegaly. Cold hemagglutinin disease can present as a primary clonal disorder, usually occurring in middle age or the elderly. You could get acrocyanosis, which is dusky blue appearances of the toes, of the fingers, the nose tip of the ears. And Raynaud's phenomenon can occur in about 40-90% of patients. Paroxysmal cold hemoglobinuria is typically transient. It presents about 2 weeks after an upper respiratory tract infection or any other childhood illness with fever, abdominal pain, back pain, and hemoglobinuria. So to actually confirm that your anemic patient is hemolyzing, you typically would find a raised bilirubin unconjugated because of the breakdown of red cells before it is conjugated in the liver. Reticulocyte count is increased because of a high bone marrow turnover. Lactate dehydrogenase may or may not be increased because it might be associated with lymphoma or not, or cancer. The haptoglobin is reduced as it binds to free hemoglobin. On the blood film, you might see spherocytes because when IgG binds, it changes the shape of the red cell membrane. Agglutination in cold disease, or polychromasia because if you have a high reticulocyte count. If you did a urine analysis, it might be positive for blood and intravascular hemolysis. Urinary hemosiderin can be detected a week after the onset of intravascular hemolysis. That's because renal cells degrade hemoglobin to hemosiderin and then shed it, and then it's detected by an iron stain in the urine. So if these things are positive on the lab results, then you would go on to do a direct antibody test to check if this is a non-immune or immune cause. So a positive direct antiglobulin test or antibody test that indicates the presence of an immunoglobulin, IgG, IgM, or IgA, or complement bound to the red cell membrane. A positive DAT in the presence of hemolysis suggests an autoimmune cause, but you need to do some further questions in the history before a diagnosis of autoimmune hemolytic anemia can be made. So you need to think, has this patient recently had a blood transfusion? Is there an alloantibody from a donor? Is this patient an infant? And are they jaundiced because of a maternal alloantibody on the fetal red cells? Have they recently had any specific drugs which can induce hemolysis like cephalosporins, diclofenac, rifampicin, fludarabine, oxaliplatin in terms of chemo, ceftriaxone, tazocin? And if the DAT is negative, then you need to think about other causes of hemolytic anemia, such as a membrane disorder, sickle cell anemia, an infection, other drugs, DIC, burns. If the patient has low platelets and evidence of red cell fragments on the blood film, then you should be thinking about ATP, which is a medical emergency. A positive DAT is not specific and is also associated with a wide range of non-hemolytic disease states. Can be passively deposited from liver disease, chronic infection, malignancy, SLE, or renal disorders, or even drugs such as intravenous immunoglobulin or ATG, antithymocyte globulin, that the patient's had recently. So we keep talking about DAT. What is it? The principle of DAT is to detect the presence of antibodies attached directly to the red blood cells, C3d, or immunoglobulins, IgG, which takes place by washing a collected blood sample in saline to isolate the patient's red cells. This procedure removes unbound antibodies that may otherwise confound the result. With direct antiglobulin testing, a monospecific reagent, so anti-human globulin antibody, anti-IgG, or anti-C3d, is then added to the washed red cells to detect bound IgG or complement C3d. In practice, many labs will first use a polyspecific reagent, so an anti-globulin reagent that can detect both IgG and C3, and then you would follow the positive result with a monospecific test to characterize whether it's IgG or C3d. NHSBT can do an extended panel which will look for IgM and IgA, so that will further look for the subtype of warm versus cold. the patient's only positive for IgG, you could probably be confident it's a warm subtype. But if there's a cold antibody detected on the monospecific DAT, then you need to work out whether it's a clinically significant antibody or it's mixed cold-warm pictures. Another way it's done in the lab is column agglutination, where the patient's red cells are added directly to the column. The column already has anti-IgG or anti-C3d in it. So if there is an IgG complement bound to the patient's red cell, then the antibodies already present in the column will bind to the red cell and agglutinate them. So you will see agglutinates form and move up the column instead of all the cells going to the bottom of the well, which is a negative reaction. How strongly positive the agglutination is on the DAT also makes a difference. If the C3d is detected, you would think, is this cold hemagglutinin disease versus mixed picture or paroxysmal hemolytic anemia? If it was weakly positive, it might be a delayed transfusion reaction from an alloantibody against donated blood. If the anti-IgG is strongly positive, you would think of warm hemolytic anemia, hemolytic disease of the newborn from maternal alloantibodies, or antibodies against a specific drug. If it was a mixed picture, again, a weaker agglutination may be an acute or delayed transfusion reaction. If it was stronger, then you think about warm hemolytic anemia, for example. So once you've done a DAT and you've detected an IgG and C3d or C3d antibody alone, you'd have to go on to do a direct agglutination test, which is a screening test done at NHSBT. You send the patient's plasma sample at room temperature. It's then incubated with a saline panel of O-negative red cells. If there is a cold antibody there, then it will bind the red cells and cause agglutination directly if there was an IgM cold antibody present, rather than rely on the anti-human globulin, which is what happens in DAT. It may be positive because of a clinical insignificant antibody. So, if it is positive, you would have to then go on to do cold antibody titers and a thermal amplitude test. So, you first did a DAT, you detected both IgG, C3d, or cold antibody, and then you did a direct agglutination test. That's come back positive. So now the goal here is to distinguish between a cold antibody reacting in a test tube versus something clinically significant. So then you need to do antibody titers and to do thermal amplitude tests. So a cold antibody titer is when you do serial dilutions, and it's the highest dilution of serum where agglutination of the red cells are still seen. So how strong is that antibody bound at 4 degrees? And if it's a 1 in 64 serial dilution, so you dilute it by 1, then 2, then 4, then 8, and so on. And if it's still bound in 1 in 64, that's a strong antibody titer. In a thermal amplitude test, the IgM antibodies are most active at 4 degrees, but they need to be active to bind to red cells at 37 degrees. So the question is, what is the maximum temperature that the antibody will still bind and agglutinate the red cells, active enough, with enough thermal range to cause hemolysis? And that's what thermal amplitude testing is. So will the antibody still agglutinate red cells, not just at 4 degrees, but also at body temperature? So you've established autoimmune hemolytic anemia, but which one is it? So for warm autoimmune hemolytic anemia, it's normally IgG autoantibodies that have bound to the red cells, optimally at 37 degrees, but 35% can be just IgG only. About 58% have IgG and C3d, about 10% have C3d only. In CHAD, cold hemagglutinin disease, it's IgM autoantibodies binding optimally at 4 degrees, about 80% is C3d only. But if you had a C3d only autoimmune hemolytic anemia, only about a third of that is due to CHAD because it's mostly warm autoimmune hemolytic anemia. CHAD must be distinguished from insignificant cold agglutinins, and that's by measuring antibody titers. So CHAD typically has a titer of more than 1 in 500, and it's normally less than 1 in 250 for an insignificant cold antibody. In paroxysmal cold hemoglobinuria, it's biphasic IgG binding at low temperatures, but causing complement lysis as the temperature rises. It's usually C3d only. In children, a Doneth-Landsteiner test is used if there's presence of hemoglobinuria and cold symptoms and you've excluded CHAD. In mixed, you could get a combination of warm IgG and cold IgM, but the titers are often low with less than 1 in 64. So this anemic patient is rapidly hemolyzing and dropping their hemoglobin. What do you do? General strategies for all autoimmune hemolytic anemia: you'd have to treat an underlying cause like infection, or if it's drug-induced, stop the relevant medication. But in life-threatening situations, always give blood. Full compatibility testing can take about 6 hours or more, so you won't have time to always identify an underlying alloantibody. Because these are commonly rhesus or KEL, as long as you do ABO, rhesus, KEL matched cells, this will be good enough in an emergency, rather than delaying giving blood until a full serological investigation has been returned. Patients with a clinically cold type antibody, the use of a blood warmer and ensuring a warm environment is rational. Specifically for warm autoimmune hemolytic anemia, you can use IVIG, about 1 gram per kilogram for about 5 days, and evidence from the case series suggests about 40% of patients respond to IVIG. It can fix the complement in acute hemolysis. Plasma exchange is more to buy time. The evidence for it is limited, as it shows that results are usually temporary, so it can be used to attempt to control hemolysis whilst you're waiting for immunosuppression to kick in and work. Methylprednisolone, again, is immunosuppression to reduce the effects of IgG autoantibodies. In patients who are severe transfusion dependent, who haven't responded to immunosuppression, may require an urgent splenectomy. The spleen is getting rid of the red cells. If the patient is too hemodynamically unstable, you could consider an embolization instead. And then you should arrange for them to be vaccinated 14 days after the splenectomy, because functional antibody responses are better after that. For cold hemolysis, in an emergency situation, steroids can be used as a last-ditch attempt, but the evidence for it working is weak. So a trial of 1 milligram per kilogram of prednisolone can be used, given limited therapeutic options. For everyone, they should have thromboprophylaxis with low molecular weight heparin. They are at high risk of clotting. Folic acid to help bone marrow turnover, as well as vitamin D and calcium in patients with high doses of steroids. So when you have a bit more time to think about treatment for warm autoimmune hemolytic anemia and the patient's not rapidly hemolyzing, you'd investigate an underlying cause by looking at immunoglobulins, whether there's an IgM paraprotein present, HIV, hepatitis B, hepatitis C tests, anti-DNA ANA tests looking for connective tissue disorders. You might do a CT if you suspect malignancy. If they have cytopenias in their blood, you'd have to do a bone marrow to check for marrow infiltration with CLL or CHAD. And if they're thrombocytopenic, you need to exclude DIC, so do their clotting, as well as check for TTP and their renal function. First-line treatment for warm autoimmune hemolytic anemia is prednisolone, 1 milligram per kilogram. The treatment for this is longer than ITP, and patients will be on steroids for much longer with a slow taper. And about 80% respond, but 20% remain in complete remission. So a lot of patients relapse, and then we'll need to move on to second-line treatment, which is rituximab, around 375 milligrams per meter square weekly for 4 weeks. Again, around 50% relapse after a few years. You might need to go on to third-line treatments like azathioprine, cyclosporin, mycophenolate, depending on your local trust. An alternative would be a splenectomy if immunosuppression isn't working. C5 inhibitors and other immunosuppressants like alemtuzumab, bortezomib, cyclophosphamide can be thought about in fourth line. So in primary cold hemagglutinin disease, it's described in patients without other systemic autoimmune diseases or infective etiologies, and they have no clinical or radiological evidence of a lymphoma. However, even if they were primary, if you did immunophenotyping, the majority of those patients will have a B clone and a circulating IgM monoclonal paraprotein. Therefore, it's hard to get rid of, and the treatments are generally more like chemo. So cold hemolytic anemia is clonal. It doesn't resolve spontaneously. The symptomatic anemia is usually transfusion dependent. If the patient has circulatory symptoms, then you need to give blood via blood warmer, ideally. First-line treatment would be rituximab. Steroids can be used to some degree, but the response isn't sustained. It's more used in the role of rescue. And again, a splenectomy is not as effective as in warm hemolytic anemia. Most patients do respond to rituximab or rituximab bendamustine second line. There is some data for ibrutinib for anemia and cold-associated symptoms. Because it's a B-cell clonal disorder, these treatments are more chemotherapy-like. But it's a low-grade clone, which is quite difficult to remove. Paroxysmal cold hemoglobinuria is caused by a biphasic IgG antibody that binds to red cells at low temperatures and causes complement-mediated lysis as the temperature is raised. The DAT is usually positive to C3 only. There may be agglutination or spherocytes by neutrophils on the blood film. It can usually be diagnosed about 2 weeks after upper respiratory tract infection. If the patient is DAT positive to C3 plus or minus IgG, but there's no evidence of ChAd or a cold antibody, but the patient has evidence of hemolysis and hemoglobinuria and cold-associated symptoms, you can do a Doneth-Landsteiner test to diagnose PCH. Or if the DAT is negative, especially in children less than 18 years old, there's evidence of hemolysis and hemoglobinuria, then you can do the Doneth-Landsteiner test. It's done by a specialist lab and a warm separated sample is required. So in summary, there's many different things that can cause hemolytic anemia. It's important to confirm hemolysis on lab tests. If a DAT is positive, then ask questions of recent blood transfusions and a stem cell transplant, the age of the patient, or if they've had recent immunoglobulins or liver disease or renal disease or connective tissue disease, whether they have any underlying infections, any drugs that they've had recently, what their platelets are, whether they need to think about DIC or TTP.